So the talk that I used to give was what you need to know about scleroderma and oral health. And immediately what I found out was that, yeah, you do need to know about scleroderma and oral health, the people who have scleroderma and their caretakers. But a lot of dentists need to know about scleroderma and oral health. Oh, there we go. Okay. So just about me, I'm a teacher at Tufts Medical Center in Boston. I teach primarily at the dental school. I have a secondary appointment at the medical school in the Department of Public Health. I also work with the Massachusetts Dental Society, and the Scleroderma Foundation is located, well, where A is on this map, that's where I live, and B is the Scleroderma Foundation. It's just coincidental. The way I got involved was in 2005, they needed a speaker at the national meeting in Cambridge, Massachusetts, and they just happened to call me. And I just happened to know a little bit about scleroderma. Now I know a lot more. Why is this not always working?
I don't know.
Oh, because a reminder came up on my computer that tells me that I'm supposed to be here, yeah. Oh, good for that. There we go. There. Now we should be good.
Oh.
All right. So immediately I'm hearing from patients, actually at the very first lecture I gave on scleroderma, I'm hearing about this disconnect where people find out they have scleroderma and they tell their dentist, and their dentist says, gee, I'm sorry, I don't know anything about scleroderma. You have to find a dental specialist who knows about scleroderma. And my first thought when I heard that was, you are the dental specialist. So I did a survey with a dental student who is now, she and I are both Emory College graduates who then went to Tufts for dental school.
Oh, wow.
And we found out that about 30% of patients have difficulty finding a dentist who will take them having scleroderma. So this is an actual number, 28%. And about 63% would not recommend their current dentist, which I thought was awful. Okay, so when you have scleroderma, there are a lot of oral health issues. It's hard, but when you go in and the dentist isn't aware of what's going on, that makes it more difficult. Then for my master's thesis, when I got my master's of public health a few years ago, I surveyed dentists in Massachusetts about their knowledge and attitudes with respect to treating people who have scleroderma. And this was published a little over a year ago in the Journal of Clinical Rheumatology. So 93% of dentists feel that we have a, oh, I left my paper over here, feel that we have a responsibility to treat people who have scleroderma. Only 70% feel prepared to treat someone who has scleroderma, which dovetails nicely with the 28% who wouldn't see someone who has scleroderma. And 50%, 51% are concerned that if you don't know about scleroderma, we might actually hurt someone. And 71% believe treating someone who has scleroderma might be time-consuming, which it is, but that's okay. Some patients take longer than others. And then I said,
could you put that slide back for a minute, because we don't have that one in our paper.
Right, because it's covered up by the next slide.
Okay, but do you mean, wait a minute?
Sure.
So 51% are
51% believe that if we don't know about scleroderma, we might accidentally hurt somebody, which I don't think is going to happen. 71% believe that treating someone with scleroderma might be time-consuming.
Okay. Which is true, though.
It is true, because many people who have scleroderma have limited opening. It makes it a little harder. You're uncomfortable, more uncomfortable than the average dental patient. We have to take our time. Sometimes, and you'll see, I recommend that we have little rest sessions during long treatments.
Okay.
So then I said, if someone walked into your office and they have scleroderma, what would you do? Well, it seems like 45% would just treat the patient and 50% would want to gather more information. I didn't think when I set up this survey, okay, so you've gathered more information, now what? But the gathering more information is important to what I'm talking about. I asked them questions about things like, what you can't see very well, especially if you're not a dentist, is that people who have scleroderma very often have a widening in the space between the bone and the tooth. That's what we're looking at here.
Okay.
It's pathognomonic. That means that if you see that, you know the patient has scleroderma, which is amazing. And this is not new information. This is information that I learned in 1981 as a dental student, and I have the citation for the textbook that I still have. Something that's brand new that is not published on paper yet, but is published online as of September, is in Canada. They did a really interesting study where they showed that people who have more of this finding have worse systemic sclerosis. By the way, my comments are primarily to do with systemic sclerosis and not morphia. I cross-tabulated how many questions they got right with their feeling that they can treat people who have scleroderma. I feel prepared to treat people. And I found that a statistically significant relationship between knowing more about scleroderma and feeling prepared to treat people who have scleroderma. And then I asked, if you would like to learn more about scleroderma, how would you prefer to learn about it? 96% of my respondents said that they would like to learn more about scleroderma. And these are the ways that they would like to learn about scleroderma. So what I'm talking to you about today is these are the things that your dentist wants to know, and you can teach them. You know, so few people have scleroderma that you can go your entire career. You can be a 55-year-old dentist like me and have never met anyone who has scleroderma, let alone see one in practice. I worked with one of our MPH students. She had previously been a research assistant at the dental school. And for her master's project, she surveyed dental schools in the US and Canada to find out what they're teaching dentists about scleroderma. And what she found out was that nearly all the dental schools teach their dental students, their pre-doctoral students, about scleroderma, but it's often just part of maybe 3 or 6 hours of lecture on autoimmune disease. You can imagine being a 24-year-old dental student, or for me, I was at the time a 22-year-old dental student for one of these lectures. And you hear this lecture, and you're supposed to remember this when you're 45 and your first scleroderma patient walks in. There's no way. I was fortunate in that when I was in dental school, I had a patient who had scleroderma. And there are not many. I did a survey recently of our practice management system at the dental school, and out of something like 20,000 patients, only about 20 of them had scleroderma, even though our school is located very close to a cluster of scleroderma patients in South Boston. Only about half the schools offer continuing education for practicing dentists on scleroderma. So the schools aren't helping us. The schools aren't going to provide information to your dentist on how to take care of you. So what does your dentist want to know? This brochure, there's copies of it outside. I wrote this. This is actually the second version, so it's a little better than the first version. I recommend getting this. And Also, if you ever want your dentist to get in touch with me, my email is on the last page of this. So I'm happy to speak with anyone. By email, email's best. So, scleroderma affects your oral health all these different ways. There's xerostomia, or dry mouth, pain and difficulty opening, oral effects of medications, psychological effects of having a chronic illness. Every dentist knows that our patients that have depression have a lot of trouble taking care of their activities of daily living. And the problem is that you're depressed and you're not taking care of your oral health, and your oral health gets worse, and then you get more depressed, so it's a spiral. And then there's, of course, gastroesophageal reflux disease and the horrible effects that that has on your oral health. This is a similar slide that I keep in my presentation because my 27-year-old daughter, who's an optometrist now, she made this for me when she was in middle school. Caries management by risk assessment. So young dentists graduating from dental school now, or some older dentists graduating from dental school now because our age is creeping up, we're training them how to assess a patient's risk for tooth decay based on a lot of factors. And then we put them in either a low risk category or a moderate risk category, high risk, extreme risk. Everyone who has an autoimmune disease should automatically be put in the extreme risk category and should get all of the treatments that I'm talking about in this in this talk. And I'm not going to list these for you right now. But let's talk about treatment for xerostomia. So there's a range of treatments for xerostomia. It ranges from just drinking more water, chewing gum, although if you're having effects of your TMJ, you're going to have to avoid chewing gum, sucking on sugar-free candies. By the way, there's been a lot of talk about a sweetener called xylitol. Has anyone heard of xylitol? Yeah. All right, so xylitol has been very heavily promoted to the dental community. And it sounds like a very good thing. It's definitely not a bad thing. But it's not having as strong an effect on preventing tooth decay as what we thought 10 years ago or 5 years ago. And it's very good for children, and it's really good for pregnant women and women with young children if they use enough of it so that they don't pass on decay-causing bacteria to their young children. So this is a highly concentrated, Cafesol is a highly concentrated calcium and phosphate rinse. It was developed at Tufts by the man who was the dean of the dental school when I was a student, and also by one of my mentors who was also a co-author on the survey that I wrote. So Cafesol is only available by prescription. It's really hard to get. It's expensive. You use it by mixing a blue and clear, the contents of a blue and clear capsule together, rinse with half of it in half of your mouth for 1 minute, and then rinse with the other half in the other half of your mouth for a minute. And it's super effective. It's very effective. But you have to use it several times a day, and like I said, it's very expensive.
Is that to prevent cavities?
No, it's actually, if you are starting to get a cavity, then this will reverse it. So one of the problems that you have with having dry mouth is your saliva has a lot of calcium in it. And if you have, and also it has a buffering ability. So if you eat something that's sweet and the bacteria starts to make acid, your saliva rushes in, neutralizes the acid, and remineralizes your teeth. And you've heard of toothpaste that can do this. This is just a very strong, super concentrated solution of calcium that does this. We can also use things like MI Paste Plus. Let's see, I think that enlarges. Okay. MI Paste Plus is a calcium paste that's made primarily from cheese, although it doesn't taste like cheese. It tastes like raspberry or like Tutti Frutti or avocado, I don't know. But anyway, the MI paste is excellent. You need a prescription from your dentist, or you need to buy it from your dentist's office. It's not available in pharmacies that I know of. It is easily available online. If they want to see the prescription, which they should, you just photograph it with your phone and you mail it to them, and that's all set. You keep it on your nightstand, and at night, right before you go to sleep, you take a bit of this MI paste and smear it all over your teeth, and then go to sleep. And this highly concentrated calcium paste helps remineralize your teeth. Even if you have a very large cavity, it will firm up the edges of the cavity so that when your dentist goes in to do a filling, the filling will be able to hold on better. GelCam and President 5000 Plus are fluoride, extra strong fluoride gels. President is exactly like Colgate toothpaste, but it has 3 times the concentration of fluoride. And then GelCam is not a toothpaste, it's just a gel that you put on your teeth. And your dentist can even make a tray that's sort of like one of these Invisalign trays that fits over your teeth and holds it on. Both of these are very effective at helping to prevent tooth decay and also helping to reverse teeth that have small amounts of decay.
You need scripts for all of those?
You need scripts for all of that. And your dentist or your physician can write you those prescriptions. Something else that's a very good treatment for dry mouth. There are 2 medications. The general class is a muscarinic agonist. You don't need to know that, but they're either Evosac, which is this one, or Salogen, S-A-L-A-G-E-N. Salogen is the original one, which was developed at Tufts by the same person who developed the Cafesol. And Evosac is it's a different chemical. And for some people, if using one doesn't work, using the other one might. They work very slowly to increase how much saliva your salivary glands make. So many times, when your salivary glands aren't working, when you have an autoimmune disease, there are still bits of the salivary gland that are working, or it will work a little bit. And we can tell the nerves using this medication to make more saliva, to tell your salivary glands to make more saliva. It takes about 6 weeks to have an effect. You take this medication 3 times a day, forever. After about 6 weeks, you'll notice an effect, and after about 12 weeks, you reach the full effect. It has some side effects. So if you're having some cardiac issues, or if you have asthma, you need to talk with your physician before taking this. If you find that you take this and you sweat profusely, which can happen because it's the same nerves telling your sweat glands to work, you shouldn't take it. You should switch to the other one, or maybe not use it, because you can sweat so much that you'll become dehydrated. Oh, also if you have narrow angle glaucoma, you can't take this. But if you have narrow angle glaucoma and you've had the surgery for narrow angle glaucoma, so most people that have narrow angle glaucoma, alarms go off in the eye doctor's office. My wife and daughter are both eye doctors, so I know about this. And then you get a surgery, and then it's your eye pressures are normal. Just stuff you can read at home later. All right, gastroesophageal reflux disease. Many times your dentist is going to be the first person to notice that you have gastroesophageal reflux disease, because we look and we see the damage that your stomach acid is doing to your teeth. And it has a particular pattern. It looks different than if you have bulimia. So in this case, this is a young man who, because of illegal medications he was taking, he was having a serious problem with gastric reflux. One thing that I noticed with him I know it's hard for you to see this, but the biting surfaces of these teeth are eroded away, except for the silver fillings. So it looks like the silver fillings, a dentist went in and meticulously made all of the fillings just a tiny bit too high. This is another gentleman who had, this is a young woman who had gastric reflux. And what I'm pointing out here is I had just treated her 6 months before for all of her tooth decay, and then she had 2 new cavities because she wasn't getting the acid reflux treated. So it's important for your dentist and your physician to work together. Your physician can call the dentist and can say, well, why is it that you think that the patient has gastric reflux? Many times I've seen that the physician has a different way of thinking about gastric reflux. They say, their thought is, it's not really bothering the patient that much, so I don't want to prescribe the medications to them. I'm afraid of prescribing antacids because they have sugar in them and they'll get cavities from the sugar and antacids. But what they don't realize is even for patients like me who aren't noticing that we have gastric reflux until I used to teach music at a Sunday school. And I noticed I was getting hoarse after about 10 minutes of singing. And that's how I knew that I had a problem. And my physician looked at my vocal cords and saw that I was burning them with stomach acid. So this is, doing that to your teeth has got to be at least as bad as burning your vocal cords, even though you might not be having such bad noticeable discomfort. Something else, many people who have scleroderma take a lot of different medications, and there are a lot of oral effects of medications. Dry mouth. So you already have a higher risk of having dry mouth when you have an autoimmune disease, but then you're taking some medications that can cause dry mouth. There are over 425 medications that have dry mouth as a side effect, including simple over-the-counter things like an antihistamine or a decongestant. Some medications can give you sores in your mouth, can irritate the lining of your mouth, can cause you to get, because you have dry mouth, more likelihood of candidiasis, which is the fungal infection in your mouth, or thrush. There was a medication that used to be prescribed pretty regularly to people who have scleroderma, and I'm told that that medication hasn't been used in a long time, penicillamine, but that would cause your gums to hemorrhage. Dysgeusia, that's one of my favorite words. Dysgeusia means change in taste. And just having dry mouth causes a change in taste, right? When your mouth is dry, you can't taste things as well. But there are 3 different mechanisms by which medications can cause a change in taste. Do any of you remember dimethyl sulfoxide, DMSO?
I've heard of it.
Yeah. DMSO is an industrial cleanser that in the 70s people found if they applied it to their joints, if they had arthritis, it would make their joints feel better. But we couldn't do a randomized controlled trial on that because you rub this on your skin and instantly you taste oysters.
Oh my.
Like that. So I don't know how you could randomly control for that. I mean, maybe have everyone eat oysters while they're rubbing whatever on their skin. Gingival hyperplasia, swollen gums. This is very common with the medications like nifedipine that you would take for Raynaud's. It's very common. If you do a good job brushing and flossing, if you keep the plaque down, you will have less of this. But every few years, some people need to go in and have their gums trimmed, which is, it sounds much worse than it is.
Sounds pretty bad.
I know, it sounds really bad, but it's done in the dentist's office, and there are some people that will even do it with a laser
I was just going to say, isn't there a laser?
Yeah, you can use a laser to do that. You can use a kind of electrocautery machine to do that. Or you can use a scalpel. And if you use the scalpel, it feels normal after a couple of days. Well, before that, it feels like maybe the worst mouth sore you ever had. So it's not terrible. It's definitely noticeable. And osteonecrosis of the jaw. This made the news a few years ago because some oral surgeons found that people who were taking bisphosphonates seemed to have, so bisphosphonates, these are the medications you take for your bones. But what they found was when they would extract teeth for people who were taking bisphosphonates, it was more likely that the bone around the tooth, instead of healing, would die and create a very uncomfortable condition. And what we found is, yes, you do have a slightly increased risk of this kind of complication, even just from having an infection. So you have gum disease, you have a root canal infection, and you're taking a bisphosphonate, especially if you're using an injectable bisphosphonate like Dedronel, you are much more likely to get this osteonecrosis of the jaw, which is an uncomfortable, bad situation and hard to treat. If you take good care of your teeth, if you have good oral health, you are far less likely to have this problem. But it's not only bisphosphonates that will cause this. There are many other medications like steroids. There are medical conditions like diabetes. So it's not only bisphosphonates. Many people who have scleroderma have trouble with their mouth being small, Xerostomia. There are a lot of ways that dentists can help with that, and there are some things that you guys can do too. Oh, I want to go back to that. So physical therapy, I'm going to show you a couple of exercises that you can do to help increase your jaw opening and your mouth opening. And it's not just that the jaw doesn't open, but it's also that the ring of your lips, the embouchure, gets smaller. Commiserotomy is something that nobody wants to be involved with. So this is where the dentist or the surgeon would actually cut into the corner of your mouth to be able to open your mouth bigger. I haven't heard of too many people being involved in this ever. Recently, I started getting emails from a young lady out in California who had, she needs to have an upper second molar removed, and the surgeon will only do it if she lets him do this surgical procedure. So she's trying to figure that out. So it's unusual, but it does happen. We can adjust the tools and techniques. We need your patience. We can shorten burrs. I'll show you how we do that. Floss with a floss aid. I'm going to show you one of those in a second. And we can take impressions with smaller or cut down trays. Now, how many of you that have trouble with small mouth have been to the dentist and the hygienist or the dentist cleans your teeth and then they come at you with the floss and the floss is running into the sides of your mouth and it's really uncomfortable, right? So this is not that. So I was in Pennsylvania years ago for a scleroderma meeting, and one of the patients mentioned this. It's the Reach Access Flosser. It's in the middle over there. The Reach Access Flosser is available at any pharmacy. It's cheap, it's inexpensive. It's basically like a toothbrush handle with a floss bow on the end of it. The floss bows cost about $5 for a month's supply. There's also this thing called the water pick flosser. So it's not a water pick. Water picks are not very highly recommended by dentists. They're not highly recommended at all. I spoke to one of my former students who's now a big shot periodontist in the Boston area, and he deserves every bit of it because the guy is outstanding. I asked him what he thought about water picks, and he says, well, it's better than nothing, which was kinder than what I was thinking. But the water pick flosser is actually kind of neat. You have this little plastic whip that sticks out of the top of it. This is a month's supply of these little whips that cost about $5. and you insert it between your teeth, and you push the button, and the whip goes around and cleans in between your teeth.
Huh.
Not as good as floss, but not bad. And the only thing is that whip, because of the way it sticks out, it's hard to get it into the side on your back teeth when you have microstomia, small mouth. Let's go back to the toothbrushes. So there are some adaptive toothbrushes for that work pretty well. The Dex brush is actually an award-winning design for people who have rheumatoid arthritis.
Which one is that?
That's the one right here. Oh, you can't really see it very well in this picture, but this is the Dex brush.
Okay.
And it used to be very well available in pharmacies. I haven't seen it that much, but it's still easily available online. It's not very expensive. The only thing is, look how big it is.
Mm-hmm.
It's pretty large. It's easy to hold on to. So if you have sclerodactyly, you can hold it, but I don't know what you're going to do with it. And then this other one is called the Benefit Plus toothbrush, which is only available online. The Benefit Plus toothbrush is 3 toothbrushes held together in a rubber sleeve. And so because it's 3 toothbrushes held together, it's a little thicker, a little easier to handle when you have sclerodactyly. And it brushes the tongue side, the cheek side, and the biting surface of the teeth in one pass.
Wow.
So it's not bad. I kind of like it. I really like these electric toothbrushes. So the Oral-B, and this is an older model Oral-B, but it's still a good one. The Oral-B toothbrushes with the little round head that goes back and forth, not the ones with the replaceable batteries that spin, but the ones that are rechargeable and go back and forth. Those are very good. I actually use one of those myself, and what I found was, after using it for a month, it improved how my teeth looked, which I was not expecting at all. My teeth actually lightened up a little bit. The Sonicare is also a very good device. It comes with 2 different sizes of heads, and I suggest the smaller head, just because it's easier to get in and control. Fluoride varnish, dentists can give you that. This is showing how we shorten burrs, smaller cut down trays, physical therapy. This is, so your dentist or your physician can give you a stack of tongue depressor blades that you put in between your teeth, and you get as many in between your teeth as you can, and then you slide one more in, put a rubber band around it. Shelley was nice enough to be my model for this. Shelley used to work for me. And then there's this exercise where you lubricate your lips. Oh, by the way, put those things in between your teeth, sit and watch TV, leave them in between your teeth for 10 minutes. That will help increase your opening. To increase your embouchure, lubricate your lips, cross your wrists over your chest like this, hook your thumbs inside your lips, and give yourself like a little tug, like that. Give yourself a little tugging. Now you don't want to make it so hard, well, you want to like smoothly go up and down like this. You don't want to make it so hard that you're tearing anything or hurting yourself. You want to just give yourself a stretch. And do that for 10 or 15 minutes a day. That's one that you can do in the shower. Please do not do the tongue depressor blades in the shower. I don't want to. These machines, the Therabyte and Neurostretch, do the same thing. You need a prescription for them. You have to buy the replacement parts. I was thinking that this was not a good idea because you can do it with the tongue depressor blades and with your thumbs. But then I saw a patient in my office who could not do that for herself. Her sister needed to do it for her. And I thought that this was a little more clinical if someone has to do it for you. So the Therabyte and Neurostretch. And these are information for Therabyte and Neurostretch are available online. Just Google it and their website comes up. Implants are okay. So that first patient who asked me about finding a dentist because her dentist couldn't help her, she needed to find a specialist. I sent her to a friend of mine. He's been taking care of her. These are His name is Thomas Cleary. He practices out in Western Massachusetts. So he did this implant for her. Implants work fine for people who have scleroderma. Something that's extremely annoying with people who have scleroderma is that the same cells that cause scleroderma can start attacking your teeth and bones. So here is, here's that same patient again, Carol. And the nerve tissue inside, the pulp tissue inside her tooth, started eating out the inside of the tooth. This is called internal resorption. And also she had external resorption, like on this tooth. So internal and external resorption. Here's the other side of her mouth. Here's a new patient to me about a year and a half ago. So this gentleman came in, he had recently been diagnosed with scleroderma. His teeth were in really good condition, except he had this one cavity, and it was this far under the gum. Now, people don't get cavities under their gum because the gum is protecting the root of your tooth. What happened was the gum tissue started eating away at the tooth. So I reflected the gum back, and I removed the tissue that was eating into the tooth, and it left this shiny hole. I saved the tissue. And we made these slides. So this is the tissue that was eating into his tooth.
Wow.
And this is this part enlarged, and then that part enlarged. So what we're seeing here is phagocytic macrophages that have eaten into the tooth. This is a little piece of dentin that's inside this tissue. Dentin from the root of the tooth.
Wow. The white part or the dark part?
This.
Okay.
I'm sorry that you can't see it very well with this projector, but dentin has a very particular look to it. It's a solid material with holes evenly spaced all through it that cells live in. So any dentist looking at this looks at that and says, what's that piece of dentin doing in the middle of that soft tissue? This seems to, so, all right, I'm an evidence-based medicine guy. I look for the best evidence. I look for numbers. I look for systematic reviews and meta-analyses. And we don't have that because not that many people have scleroderma, and it's hard to work up a big number of cases. But from talking to people who have scleroderma, from being in rooms like this, I've seen that there are a steady number of people that have something called multiple tooth resorption syndrome. If you don't have scleroderma, the risk of having multiple tooth resorption syndrome is where multiple teeth start getting eaten away by your soft tissue. It's about 1 in a million, maybe 2 in a million. For people who have scleroderma, I think it could be as high as 3 to 5 in 100. So it's significantly higher. It's not affecting everybody. And if you have this, there's no way of knowing what's going to cause it, what's going to make it stop. There isn't a treatment for it, except that as the tooth gets a hole in it, we fix it. I have to press on. So anyway, I have one quick question. For those of you, how many of you have Raynaud's? Okay, and how many of you who have Raynaud's have it affect your tongue? 1, 2, anyone else? 3? Okay. I had never heard of this until 2 days ago. Someone asked me about that. So that's good to know.
When you say affect the tongue, did it get cold?
Yeah, so what I've heard just in the last couple of days online on a discussion group is people who have Raynaud's tongue, when they have Raynaud's, maybe affecting their fingers or maybe from drinking something cold, their tongue changes color and it makes it so that they can't talk well. Does that sound right? Yeah. If any of you could send me a picture of that when it happens, don't make it happen to send me. But I would love to have that because I've only just heard about this. So tell your dentist you have scleroderma and how it affects you. Bring a list of medications, what the dosages are, and who prescribed them to you and for what. Short appointments. You probably want short appointments. Schedule appointments that are at the best time of day for you. So like my staff knows that I'm not doing root canals at 6 o'clock at night because I'm tired. But if one of my scleroderma patients says, look, 6 o'clock, earlier in the day is bad for me, I need to come in at 6, we will do that. Physical therapy right before, the 2 exercises I showed you. You could even do it in the waiting room, or not the waiting room, but maybe in a treatment room while you're waiting for the dentist. Please bring gloves and a blanket to the dental office because we're wearing all this gear. We have the air conditioner running. My staff knows to turn off the air conditioner if we have someone with Raynaud's who walks into the office, but the office will already be cold. The dentist can help you, can help make you more comfortable using a mouth prop. This is an old-fashioned mouth prop. We also have little rubber and plastic things, wedges that go between your teeth. We can use a rubber dam, the sheet of latex, or, well, hopefully not latex now, but silicone rubber that has holes in it, punched in it, that your teeth stick out through so you don't get a whole lot of gunk in your mouth. Lots of patience for the dentist and the patient. And let's see, we talked about that already. See your dentist once every 1 to 4 months. It prevents the need for long appointments and helps maintain good self-image. And this is my contact information. And people get in touch with me all the time by email, and you're welcome to if you have questions or if you would like your dentist to have some information. Yes?
Ryan, do you have a few minutes for questions?
Okay, thank you. Yes?
I have 2 questions. One for grinding of the teeth and GERD. My dentist has recommended some of the plates that you stick in your mouth, but I didn't know because of the acid reflux if that would hold the acid in there, having that.
That's a good question. So
Can you
the question,
repeat?
yes, I'm going to do that. So the question is, if you have acid reflux and you have a TMJ issue where you need to use a mouth guard, is the mouth guard going to hold the acid against your teeth? You know, no one has ever asked me that. That's a very interesting thought. And what I would recommend is that your dentist also prescribe something like MI paste or a fluoride gel for you and put that inside the tray to hopefully exclude some of the acid and to help remineralize your teeth. It's a very effective treatment.
And he had a hard time numbing me when he was filling cavities. He said I was like 1 in 100, where he actually hit the nerve to numb me. And I didn't know with scleroderma patients is that something that's typical or other than
I haven't come across that, but some of us are harder to get, and I say us, not that I have scleroderma, but I'm someone who's really, really hard to get numb. So there are some people that are very hard to get numb. Anything else? Yes?
So, unbeknownst to me, my mouth is getting smaller because the skin's getting thicker like on my hands.
Right. Well, not necessarily. If you're not noticing it, then it may not be. Not everyone who has scleroderma gets this microstomia, but a lot of people do. Yes?
So as a scleroderma provider, first of all, thanks for coming out.
My pleasure.
Great, just one other area that we need to focus on that we don't often focus on enough, and it's helpful to hear your expertise. The question that I'm asked a lot is whether scleroderma poses a specific risk for various procedures, whether it's dental extraction or a root canal. So dentists will often, via the patient, come back to us and say, hey, please ask your scleroderma doc, what kind of precautions they may need to take. Is there a sort of an easy answer for that, or are there things that we should be advising our patients to talk to the dentist about?
So the big problem, did everyone hear that? Are there any special issues associated with having scleroderma with respect to having dental procedures done? So implants, definitely not. Implants are not a problem at all. Orthodontic treatment works well with people who have scleroderma, but I just had lunch with an orthodontist who's treating one of my patients on Thursday. He said that the important part of having braces and scleroderma is that constant pressure that's happening against your teeth. You need to do something to counteract it. So you know how after kids get braces, they get a retainer? You need something like that that you would use forever, having scleroderma. And that something might be one of these clear Invisalign covers for your teeth, or it might be a wire that's attached to the back of your teeth, or it might be a traditional retainer that you would just wear at night. In terms of fillings, the big issue is with dry mouth and gastric reflux. The fillings are much more at risk. So that's something that we always have to be concerned about. But that's with anyone at risk for more decay. So that's an issue. And then the nifedipine causing swelling in the gums. So there are these few things that we do know about. But mainly, the important thing is to treat people who have scleroderma carefully, just in terms of they don't open as big, so we have to use smaller instruments sometimes. And that's not everybody, but many. And really be on top of it so that they don't get into worse issues. Yes?
I have sleep apnea.
Mm-hmm.
I have to sleep with the mask on.
Sure.
So all night long I'm constantly waking up because my mouth is so dry and I'm drinking water or spraying.
Right.
Do you have any recommendations of what I could do?
So with sleep apnea and using a CPAP machine, and your mouth is dry from the CPAP machine. First of all, I'm only moderately familiar with CPAP machines. Can they be humidified?
Yes.
Yeah? Okay, so that would be really good to humidify it, and also to use either a fluoride gel or calcium paste on your teeth at night. Yeah.
Does she have a chin strap?
Do I have a chin strap? No.
That's your problem. You gotta have a chin strap. It's drying out because you're opening your mouth.
Right.
It should come with a chin strap. Pulls up and goes around in the.
And I've seen those, but when I do close my mouth, I grind my teeth. And now my teeth are
Well,
loose because
I'm there too.
Well, your teeth might be loose just as a side effect of the scleroderma because of the way those spaces around the teeth and bone get wider. And that doesn't necessarily mean that your teeth are at risk. That's just something that happens with scleroderma.
Yeah, got the guard.
Yeah, one more question. One more question.
I have a question. Since both of you are here, this is good because I've heard that some dental procedures release bacteria, and since we're so immunosuppressed, do you recommend anything before treatment, like a prophylactic action before treatment?
In most cases, no. Yes.
So to answer Sandy,
Yeah.
we will tend to recommend antibiotics in patients who are more immunocompromised than just having scleroderma. Right? So our patient who is on chronic, moderately intense immunosuppressive medications, we will recommend immunosuppression, not necessarily evidence-based, but just, there is a transient period of bacteremia, bacteria in the blood associated with different dental procedures, and endoscopic evaluations and biopsies and whatnot. And so for those patients who are on moderate immunosuppression, be it rheumatoid arthritis, lupus, transplant patients, scleroderma patients, we often recommend antibiotics around the time of the procedure. There's
Dr. Fisher, right? Yeah, there's absolutely no evidence for pre-medication, for antibiotic pre-medication, but we still do it in many cases. But you really have to do it on a case-by-case basis because you're more likely to have, for a lot of people, you're more likely to have a problem with the side effect of the antibiotic than you are from not taking the antibiotic. Right?
Yeah, I mean, again, it's not evidence-based, it's just trying to play your odds and see.
Right. Almost 100 years of not evidence basis. thank you all.